Dr. Bohm, thank you for joining us. Your trial, it's very interesting to all interventionalists, current and future. Can you tell us more about it?
For the last key secondary endpoint, unplanned revascularization, there was no difference between the study groups as well, although there was a trend towards benefit for complete revascularization. I can also add that there was a trend towards a benefit for a secondary combined endpoint of cardiovascular death, myocardial infarction, or unplanned revascularization, and that was not significant, but it was very significant if you combined any revascularization, so planned and unplanned revascularization together. Those two you could significantly reduce by doing a complete FFR guided PCI of all non-culprit lesions sometime during the index hospitalization.
Thank you for sharing that. How did you find yourself in this trial space, in this area of interventional cardiology?
So exactly what you mean, how did I find myself?
So I think nowadays there's so many subsections, even in interventional cardiology. How did you find your interest in STEMIs in this non-culprit lesion revascularization?
Oh, okay. Well, I was starting as a interventional cardiologist at Karolinska University Hospital in Stockholm in Sweden, and then I was just doing my first years as an on-call physician, doing STEMI in the middle of the night. And then the question came up, what should we do with these non-culprit lesions? And there had just been a few trials out, like the PRAMI trial came in 2013, and then the culprit trial and Primulti, and we said, why don't we do a large study in Sweden? Since we have a good registry there, we can randomize the patients directly in the registry to do a registry randomized clinical trial.
Gotcha. What challenges did you encounter while you were going ahead with this trial? I'm sure the process involves a few challenges.
Yes, there are always challenges, and it took a while to program the registry and the homepage to be able to randomize patients directly in the registry. That was one thing. And then the inclusion rate, the enrollment rate was not as high as we hoped for to start with. So therefore we realized that we needed to expand to other countries as well to get enough patients in a reasonable amount of time. So that also took some time to with all the applications and all the authorities in other countries.
And I'm sure some of the design was, it goes against the current principle of revascularize everything, either in the same PCI or within a couple of weeks, or that hospitalization. Did you face any struggles getting people to join on board the trial?
No, not really, because at the time when we were enrolling, that was between 2016 and 2019. The data was more unclear of what was the best practice for hard endpoints. So it's quite easy actually to get doctors to enroll patients.
Gotcha. And as we talked earlier, you are an FFR enthusiast compared to the IFR concept.
Yes, yes. So our hypothesis was that FFR-guided PCI of non-culprit lesions would be better than culprit lesion-only PCI. So,
did you guys end up FFRing anything that was in the moderate and the severe range, or if it was already angiographically severe, you would proceed to PCI?
so we had a recommendation that you should try to do FFR if you randomize to that arm in all lesions. But if they were very tight, like 90 to 99% stenosis grade, then it was not mandatory to do FFR. Then you could just stent up front in that arm.
I see. So the threshold went from 70 to 90, 99%.
Well, actually, all lesions that were from 50 to 99%, they were eligible to be included as non-culprit lesions.
Did you have to exclude any patients because the wire would not cross the lesion, or it was a complex lesion?
Yes, there were a few patients, but not many. I think maybe 5 or so where the lesion could not be crossed by an FFR wire.
Gotcha. And as always, cardiogenic shock patients are out of the question.
Yes, so there were only 3 exclusion criteria, and there was prior CABG, it was cardiogenic shock, and there was left main disease that needed treatment.
Was there a point in this trial where you felt that this is going to be challenging, or you're not going to finish? Or
well, it was when the complete trial was published in September of 2019, we discussed whether to go on with our trial, or if we were to halt enrollment and follow up the 1,542 patients that we had already enrolled. So we decided on the latter because many operators felt it was unethical to randomize patients after the complete trial publication had been published, and that may have also, if we were to continue the study, meant that doctors may not have want to include patients with severe lesions or with 3-vessel disease, and that may have sort of diluted the overall results. So therefore we decided at that point to prolong the follow-up of our already included patients and expand the primary endpoint to from both death and myocardial infarction to also include unplanned revascularization, and do it as an event-driven study to get enough events. So that was some tough discussions at that time, but I think I'm happy that we pursued in that way.
No, in the world of interventional cardiology, a randomized trial, your sample size is large. We don't see that size trials often. So I'm pretty excited, and I'm sure that this will make people think and pause, and maybe bring FFR back into the picture, at least in the United States.
Yes, I mean, I think the jury is still out regarding what is the best way to do complete revascularization in these type of patients. There's an ongoing study now called Complete 2, which is led by Professor Shamir Mehta in Canada, and we're part of that in Sweden. I'm the national coordinator for Sweden, so I'm really looking forward to the results of that study, where they're randomizing between angio-guided complete revasc by visual estimation of stenosis severity, comparing to FFR guided or physiology guided complete revascularization in 5,000 patients. So it'll be a large study with both STEMI and non-STEMI patients, actually.
I see. This is a question a little off to the side, but what would you say is the percentage of your imaging guided revascularization?
Well, we didn't collect data on imaging in our study, actually, since that was not our main point of interest. But looking at the registries, the Sweetheart registry in Sweden, we know that around 20% of all PCIs are performed with some sort of imaging, either IVUS or OCT. And that's, of course, one other important issue, both in the complete study, which will be an imaging sub-study with OCT, and some other ongoing studies to see if we should treat vulnerable plaques with stents or not. So that question is still is not answered yet, I believe.
Now, the reason I asked that question, there's a push across the globe to do more imaging guided PCI. And it's interesting you brought up the vulnerable plaque, because I'm interviewing another faculty member who's doing this exact study, PCI versus medical therapy for vulnerable plaque. So it ties in nicely. So, no, but thank you. Thank you for your time. For more content and videos like this, please follow us on FITsOnTheGo.